So firstly, thank you all so much for being here today. My name is Tanaya Narbey and I'm a Senior Project Officer at the Matilda Centre. Today I'm presenting on behalf of Associate Professor Christina Morell, who at the last minute could not be here today. So I did want to acknowledge I've got very big shoes to fill, but I will do my best to fill those big shoes. So Christina leads a program of work focused on treatment and translation in complex populations, and in particular, working with the AOD and mental health sectors to effectively bridge the evidence to practice gap and finding ways of getting best practice research findings into the hands of clinicians, clinical practices and services, so it can ultimately influence the lives of people who experience mental health and substance use conditions. And that is what Belinda and I will be speaking about today. Some work that has been done with the sector, specifically in relation to developing the guidelines on co-occurring alcohol and other drug and mental health conditions, and how they've been used in practice. Before we get started today, I did want to take a moment to acknowledge the traditional custodians of the land in which I am lucky enough to live and work on, the Gadigal people of the Eora Nation, and pay my respects to elders past, present and future. I would also like to acknowledge the many people with lived and living experience of mental ill health and substance use, as well as their families, carers and loved ones, many of whom have contributed so generously to the work I'll be speaking about today. So in terms of what we want to cover today, I'm going to start with a bit of an overview and background, what we have done, how and why, followed by talking a bit about dissemination, translation and evaluation. Or how do we know if what we've done is making a difference? And then I'm going to hand over to Belinda to talk about implementation and clinicians and how clinicians and services are using what we've done in practice. Oops, sorry. There we go. In terms of background and why we have developed these resources, and I'm aware I'm going over content that you're all familiar with, so my intention is not to tell you what you already know, but just to bring us all to the same page. We know that mental health and substance use conditions are common. They are two of Australia's most common and burdensome health conditions, affecting approximately 1 in 5 Australian adults each year, and they frequently co-occur. It is estimated that about 1 in 3 of Australians with a substance use disorder will also have a mental health disorder, but this rate can be as high as 1 in 2 among people seeking treatment. In terms of the most common mental health conditions that we see co-occurring with substance use disorders, these are typically the same as those we see in the general population, which are sorry, I think that was meant to be... Is it? Sorry, Chris put some funky slide designs in her PowerPoint and clearly I'm not familiar with those. It is, yes. Thanks, Erin. I'll start that slide again. In terms of the most common mental health conditions we see co-occurring with substance use disorders, these are typically the same as those we see in the general population, which are anxiety and depression, PTSD and personality disorders, but we also see elevated rates of bipolar disorder, OCD, psychosis, eating disorders, and ADHD. And the fact these disorders co-occur is problematic, as once they are established, each serves to maintain and exacerbate the other. Okay, I think we're back on track with slides. There are so many people who experience symptoms of disorders but don't necessarily meet the criteria for a diagnosis of a disorder. And this means that many people can still have their lives disrupted by symptoms of mental health disorders, but without meeting diagnostic criteria, they sometimes fly under the radar of some services. And of course, not only do people with co-occurring conditions experience symptoms of their mental health and substance use disorders, they also have complex presentations which can complicate treatment and recovery. And research has shown that people with mental or substance use disorders die an astonishing 20 to 30 years earlier than the general population and spend the last 10 years of life living with disabling chronic illnesses. In fact, co-occurring mental health and AOD use has been identified by the Mental Health Commission as one of Australia's most significant health challenges. But these diseases are not an insurmountable barrier. Research has shown that people with co-occurring mental health conditions can benefit just as much as those without from usual AOD treatment. And this brings me to the first edition of the guidelines, or the Guidelines on the Management of Co-occurring Alcohol and Other Drug and Mental Health Conditions in Alcohol and Other Drug Treatment Settings, which were first funded in 2007 by the Australian Department of Health and Ageing as part of the Comorbidity Initiative. Led by Professor Catherine Mills, who I'm sure many of you know, and published in 2009, they were developed due to the lack of resources on co-occurring mental health conditions that were available to AOD workers. A Victorian review had been conducted a few years previously and reported that AOD workers felt overwhelmed and fearful when treating people with co-occurring mental disorders, which was attributed to their lack of knowledge and available resources. The need for AOD workers to have access to educational resources has been identified by numerous reviews and policy documents, as well as by AOD workers themselves, including the most recent National AOD Workforce Development Strategy and the current National Mental Health Workforce Strategy. The first edition was an extremely successful clinical resource, and the growth in research relating to the management and treatment of co-occurring conditions led us to developing the second edition, which was published in 2016. The second edition was also accompanied by an online training program to facilitate the uptake of guidelines into practice. And again, in 2020, the third edition was developed to reflect the most up-to-date evidence, which was published in 2022. And the guidelines aim to build capacity in the AOD workforce in relation to mental health by providing practical, evidence-based guidance for AOD workers on the management of mental disorders in alcohol and other drug treatment settings, and aiming to increase the knowledge and awareness of co-occurring mental health conditions in AOD treatment settings, improve the confidence and skills of AOD workers, and increase the uptake of evidence-based care. The guidelines were developed primarily for AOD workers, meaning all those who work in AOD treatment settings in a clinical capacity. This includes nurses, medical practitioners, psychiatrists, psychologists, counsellors, social workers, and all other AOD workers, including those working both in government and the non-government sector. Although these guidelines focus on AOD workers, a range of other health professionals have found them useful. Development of the third edition of the guidelines was based on feedback and guidance from a panel of experts, 2 discussion forums that were held online and were open to any interested stakeholders across Australia to attend, online surveys, direct submissions, and a synthesis of the best available scientific evidence. And I know some people here were involved in the development, so I really want to thank you and everyone who was so generous in contributing their time and expertise to the development of this edition and the previous editions, to make them as useful and relevant as possible. One of the reasons why these guidelines and other resources have been successful is because so many people from the field have contributed to them, which has also enabled us to continue to obtain funding to support them. Just to quickly highlight some of the main changes between the first and second editions, this is mainly a look back for those of you familiar with them, and a history recap for those who might not be. Many of these changes were a result of discussions and consultations with the field. The second edition of the guidelines were framed to take a more holistic perspective, meaning there was the inclusion of a chapter on holistic care, which discussed the importance of considering the whole person, taking into account their diet, physical activity, sleep, smoking, as well as their AOD and mental health, and also included physical activity, complementary and alternative therapies, and treatment approaches. We also included discussion of e-health options where there was the evidence. We added ADHD and eating disorders, integrated cases throughout, made new chapters on risk assessments, which considered the risk of suicide and domestic and family violence, and a chapter on worker self-care. And finally, we combined the section on management and treatment approaches rather than having these as two separate sections, and grouped them by disorder for easier identification. And again, highlighting some of the main changes between the second and third editions, many of which were also the result of discussions and consultations, though not as dramatic as the previous changes. The only new chapter that was added in this edition was trauma-informed care. But of course, the evidence across all disorders was updated, and we tried to make the evidence easier to apply to practice in this edition with more practice-focused examples. We continue to emphasise the importance of using person-focused, non-stigmatising language, but reflected terms that would allow workers to communicate with other areas of health. And we also kept the information on management and treatment together, grouped by disorder. So, we have these evidence-based guidelines, but they're not particularly useful on their own. What's important is how we're able to get that information to clinicians and services who are working with people with co-occurring mental health conditions. And crucially, how can we best get this information to people across multiple levels of the workforce, and those working in the field and those undertaking their studies. And this is always a work in progress, in collaboration with the field, but to date, this has involved a multi-pronged strategy comprising distribution, training, and program evaluation. Firstly, starting with distribution, which is fairly straightforward, the guidelines are available in PDF for download, which can be done via our website, in sections in a build-your-own customizable format, or in the full version. We also have an online version of the guidelines, which can be narrated and translated into different languages. In addition to this, there are downloadable screeners, assessments, and other free resources. And we have recently been funded by the Australian Government Department of Health and Aged Care to print and distribute hard copies to all Australian AOD services and educational institutions that provide tertiary training in AOD and mental health across Australia. This began in December last year, so Chris hopes you all received your end-of-year gifts. To date, we've distributed around 8,000 copies of the third edition across Australia. Secondly, and going a step further, we have developed free online training to support the guidelines content and facilitate uptake into practice. The program consists of 12 modules, takes around 10 hours to complete, includes quizzes, is linked to key learning outcomes, and continuing professional development points are available depending on the professional registration bodies. The online training program was released in January 2023, and since then, more than 2,600 people have been using the training, with just over 500 completing the full program. We have also developed a more skills-based training program based on a Train the Trainer and face-to-face program. This training has just been updated with the third edition content, and we're hoping to hold some Train the Trainer workshops later this year. And finally, we have a series of on-demand, evidence-based webinars which are also available via our website. We'll be holding one in a couple of weeks, and again, those details can be found on our website. I also wanted to mention that we're in the process of developing an online community of practice for practitioners working in the AOD sector, which will be a place where professionals can exchange knowledge, resources, and ideas regarding the management of co-occurring AOD and mental health conditions. We're just about to start consultations with the field tomorrow, in fact, so it's a very busy week for our team, and so stay tuned. Finally, how do we know these activities are doing what we hope they're doing and making a difference in building the skills, knowledge, and confidence of AOD workers? We are currently evaluating our online training, so I can't tell you about that just yet, but I can say that findings from the evaluation and the second edition of training, which this program is based on, were very positive, and indicated that 95% of participants reported gaining skills to enable them to respond to co-occurring mental health conditions. 94% reported the training was useful or very useful. 94% reported greater confidence in responding to co-occurring mental health conditions. 87% reported having used what they had learned in clinical practice, and 59% reported improved client outcomes. Findings from an evaluation of the Train the Trainer program also demonstrated positive findings, with participants' knowledge, skills, and confidence increasing by an average of 30% after completing the training. The evaluation of the face-to-face training is underway. And finally, evaluation of our most recent webinar series demonstrated an average of 85% of live attendees found the webinars useful. So that's good. We think they're going where we want them to do and doing what we want them to do. But how do we know that? How are they actually being used in practice by clinicians and services? And I'm going to hand over to Belinda to talk through this.
Thank you. Yes, thank you. I'm assuming it's the large green button. Okay. Thank you for that huge overview, but really, really helpful in talking about implementation. So I guess, like for a lot of you in the NGO sector, we see lots of different resources come through over the years. I'm always interested in the documents turning into implementation, what that actually looks like in practice for us as clinicians. So just to plug the service, of course, there's been a bit of a youth focus today, which has been really lovely for me. And in case you hadn't noticed, Lisa Dukes and I do know each other. We had the privilege of having Lisa be the first psychiatrist to work in our service many years ago, 2010 or something like that. Yep. So our service is in the Northern Sydney area. We cover the Northern Sydney area, and we have 2 sites, which is at Manly and St Leonard's. We work with young people between the age of 12 and 25. I do not have thousands of 12-year-olds, by the way, coming in the door. People often get quite, yes, so far. Yeah, your view, 30%? Yeah. We've definitely seen the age of initiation drop, which is why they took us from 14 down to 12 in the first place. So we do work with co-occurring drug and alcohol and mental health. I've not met a pure drug user in my 28 years, and I think that's important for us to say that, you know, clearly that tells us a lot. But traditional services, we've had to come a long way, and I think we're still getting there. We support young people, but we also support parents. And so the parent work that we started about 20 years ago, and I know that Rob, we were just talking before, I think it's 15 years ago that Tools of Change came out, and I think we were one of the only services that were doing youth-specific family work at that time. And that's been an area that we've really had to grow. The research talks about the importance of family inclusivity, but what that means in practice is often depends on the agency or what people believe that family work should look like. What we do know, though, is that those families that are presenting sometimes can present at a different time to the young person. So in our service, 12 to 25-year-olds and the parents of young people that may present with those issues are seen by separate counsellors. I'm not interested in refereeing, or I'd buy a whistle. It's also really important for young people to not feel ganged up on by adults who are very, good intentions do not equate great service delivery. And so what we do is we work with them separately. So we put parents through a 6-week course, which is about stabilisation more than anything, because they're very, very distressed. And you can imagine with young people, the distress is heightened, the desperation. I always say if transference is a colour, I feel like a rainbow after I've been with parents that are experiencing their young person and just their lack of ability to be able to access services. We do work within a harm minimisation framework. Everyone says that. We do. I think I would guesstimate, we're doing research at the moment, that probably about 70% of our clients are there for harm reduction. They are generally coerced in to the service. I don't have 15-year-olds popping in going, I'm so done with my cannabis use, I'm over it. They're generally warming up. And so in that sense, we are at that developmental stage as well of when we can see, mental health illnesses potentially coming up. We do work with the trauma-informed framework, and I don't say that tokenistically. I have to acknowledge the lived experience talk that you did earlier, which is beyond moving and reminds all of us the importance of treating people as individuals and meeting where they're at. Seeing young people come through the service highly pathologised. Parents will either sit in complete ownership and guilt, or they'll give birth to a psychopath. That's pretty much the two areas that I will see. And you can imagine the complexities of seeing those young people. It's not what is wrong with you, it is what's happening for you, and that's how we try and always work with our young people. We do work within a systems framework, and when I say that, we look at everything that creates the perfect storm for that person that has come into the service, and it is a perfect storm of things, but there is a sense of pushing people in sooner, particularly usually the focus around mental health and stopping them. We've got to stop them. That's a very common thing that's still around. And so our model, as I said to you before, we separate parents and young people. What we see over a period of time is a stabilisation. So sometimes we've got to work with the parent around their mental health and drug and alcohol, and then the young person as well, simultaneously. So when we see case reviews of both sides of the family presenting, that's kind of the ultimate thing to be able to do. And then we actually see better outcomes when there is a level of family inclusivity, keeping in mind the fact that a lot of young people are from out-of-home care and don't have those opportunities for that sort of sense of stability, and we know it makes a difference. It's our service area. So how young people present, it is really interesting. I think for those of us in drug and alcohol, we see the really good stats around how many people experience these things in drug and alcohol. And I always think it's like conservative, because I'm still yet to meet kind of a person that doesn't fit into some form of category, for want of a better term. But what we do see is, and also just being mindful that this is a developmental period. So if you are working with someone that may be developing illness, it's very mimicked by a whole lot of other things. So when people sort of say to me, even around someone working with trauma, you know, we know that there's trauma there and they're really dissociative. It's like, but they're smoking 50 cones a day. So, yeah, we have to be mindful of language and putting people into categories, which I will get to the importance of why the comorbidity guidelines have been important for us. So obviously, mainly around mood and anxiety kind of symptoms of what we actually see. I have to say, we've had quite a bit of an increase in young people in the criminal justice system. We all know there's a lack of services for young people generally, but that brings in a different element, because quite often those clients who are, you know, acting out for a variety of reasons get into the criminal justice system and they slip through the cracks with every service. So if they're aggressive or violent, they will be excluded quite often from services, and that's a whole area that we have to try and work with and stabilise young people, and we do. We see a lot of violence towards parents now. That's been a huge area that we've been working in as well. So in 2008, who remembers the DD-CAT? Yeah, I love the way all the old veterans are at the front. We all went like that. It's all right, maybe the rest of you chose to forget it. The DD-CAT, which came out in 2008, was, and we've talked about this a lot today, about capacity building in the sector and the importance of that. And we know for those of us working in services, there's an incredible lack of people who can work with co-occurring in a way that they're confident in, and also seeing the sector actually build capacity in that area is very important. So we kind of did the capability assessment, and like many of our services in NGOs, there was a importance to build capacity in those workers because of the separation between services, which is what people still always ask, why is it still separate? It's like there's a lot of us that don't think that way, but I think it's something that's historical, right? Like 1800s historical, it was all separated back then, and we're still bumbling our way back together. So what we did at that time is, once we identified that, we did the audit tool, and we could kind of see that, yes, that was something we needed. Simultaneously, in 2009, and I was just talking to Kath Mills before, the year that they birthed the comorbidity guidelines was the year I had my twins. So it's the only reason why I remember what year it came out. But for us, when we first saw it as an organisation, it was like, wow, where has this been? It was something that kind of at least attempted to try and blend, you know, the two different areas. But I think what was really important is there's this resistant, and I'm talking very generalised, resistance from both sides around the importance of each other's work. And there was also the general thing with NGOs when we talk about collaboration, how do you work with a medicalised system in the sense of what we're doing in AOD? And the importance of that is we'd love to jump ahead and change all the language, and we need to do that, and we need to change stigma. But when you're working with services and systems that are still there, we do need to be able to understand each other's language. Whether you agree with that or not is one thing, but if I'm talking to another psychiatrist and I use criteria, it's to have a fast conversation. That's what it's about. And I think there's still a long way to go in kind of humanising the language. I think drug and alcohol is behind mental health, actually, in the sense of that in some ways. There's a lot of stigma on both sides. And when you've got co-occurring, the stigma attaches to the person, the family, and then you put criminal justice on top of that and all of those other really complex things. So we put the first edition in, and that just kind of was a hard copy at that time. And then in 2017, it seems like a big gap in between, but I do want to say that we did use that, not in an embedded way in the service, more in a way of making sure that the team had copies of those certain resources so they could read through. And then what we found is, because the information in there was really helpful for clinicians, so in our particular service, people do need to have levels of counselling and therapeutic ability to work with young people. However, you can get people from all different parts of the sector that will come in, and how do we really make sure that we work with them, engage with young people in the service. So one of the things that we always find is that the guidelines were helpful for us because people could be in the developmental part of illness, or they're experiencing symptoms that can be quite confused with drug and alcohol. So it's not about trying to find what is the root cause. I think it's always a perfect storm, but it is about getting people to think more outside the square in the fact that mental health issues, which includes things like trauma, we talk a lot about trauma in most services, but I think there's still a need to change the way we approach it much more. Okay. So what we do now is when clinicians, and we just got 4 new clinicians, which we had to beg and scrape and find. It's so hard to find workers that want to work in NGOs and different parts of the sector. But when we do that, what we know is that we need them to have some clear understanding. Even if they've got some understanding, we still want them to, for continuity across the service, you really want to make sure that your team are all kind of speaking from the same platform. And I guess the guidelines actually give us the initial platform. And what we do now is that part of their induction and orientation is they actually have to complete it. So that is in their first week of orientation. And then what's kind of good about that is we do, because when clinicians come in, and for those of you that are managers, you can see people's resumes and you can look at all that sort of stuff, but when it comes down to actually understanding different information, you can't kind of audit it all the time. Like, what do you know about this? And what do you know about this? And spend a week talking about one drug. It's a difficult thing to do. So if you've got sort of kind of a good understanding across the service, then you've also got areas that you can work on more with different individual team, but at least you know that they've got that information that's available, and it's a constant resource that you can go back to as well, so we now have hard copies of the current edition as well. So we have one in every clinical office. I think we've got 10 clinicians. And that's also because they can pull it up online, but at the same time, I don't know about you, but I still go back to different resources at different times to make sure I've got it right, because sometimes clients can talk with great conviction, and I kind of think, oh, maybe I've got it wrong. But we should be checking. We should never think we've got it right. We should always be checking and be curious. And I think the co-occurring gives us an opportunity to be able to look at those things together. Advantages for your service, though, and I have to say, firstly, we've built these relationships. I feel really privileged. There's an incredible amount of collective wisdom in this room today, and I feel really privileged to have seen some of these changes come in my, not as long as Carolyn, but, getting in there. But where it can actually really help your service, and I think this is an important part. Firstly, our service received 2 different ComDan grants. I just have to do a bit of a plug for ComDan. I really do, because doing that introduced us to some of the relationships we have with Matilda as well. And the ComDan grants gave us the opportunity to look at these things more holistically and do our own grassroots research without database. It's challenging. But those relationships have been important. So when we've ended up working with Matilda down the track, it feels easy. I don't feel like there's kind of people over here, these kind of researchers that talk with numbers and freak me out. It's actually really collaboratively, you just don't feel that anymore. There's a difference. What it can do, though, is your continuous quality improvement. So we know that as we work through professional development stuff and build capacity in our teams, that's a box to tick. It's an important box to tick. Funding submissions, so we all know that to actually put in there about our narrative of how qualified our staff is and making sure we have mechanisms to show that. So I'm very excited about the dashboard that's happening. Erin will probably talk about it at a different time, which is a way for us to actually monitor and see how our clinicians are doing in relation to the information. And I must say in that as well, in the comorbidity guidelines, I don't know about you, but I'm often in session and I might be, where's that worksheet? This is how I used to do it. Where's that worksheet on that? Where's that? All the time. And now with the guidelines and the hard copies, you can actually just go to it. You can pull down, their worksheets are really good. I find them fantastic for my clinicians. And then it's something that if they're unsure about it, they can actually come to me in supervision and we can nut out more about how to implement that effectively when they're working with their clients. Because as I said, the information is amazing, but we still always have to look at that implementation part of how you communicate that with workers. And I think that's where us at the front line can complement the work that's done with Matilda by actually helping develop that those discourses in our sector. It does assist with supervision and mentoring. I find that something I can come back to all the time. I did do the train the trainer component, which kind of probably won me even more in the sense of the importance of having something like that in the service. So for us, it's been a really positive experience. There was nothing like it. I don't think there is anything that's equivalent to it. No. But we've found it really important. And also, it's hard for us in NGOs because we want to be staying in the space we stay in, which is the connectedness with community and the client-centred stuff, but being able to walk the lines of bureaucracy that can be really difficult and oppressive at times. So how do we get really creative and chip our way from the inside out? That's probably the only reason why I've stayed for so long, is I believe really strongly in that. Okay, thank you.